All right, well, welcome everyone to today's VACEP Presents. This is our online event from the Virginia College of Emergency Physicians. My name is Jeff Kelly, and I handle communications for Virginia ACEP. Today, we're going to dive into the details and the differences between a medical and behavioral health ECO and TDO, that's emergency custody order and temporary detention order. And you'll sharpen your knowledge of how emergency physicians, family doctors, and other medical providers can use these tools appropriately to get your patients the care they need. So first up are two expert panelists. Dr. Joran Sequeira is an emergency physician and medical director at Southside Medical Center. She serves as the president-elect of the Virginia College of Emergency Physicians, where she represents all of the Commonwealth's ER doctors, their teams, and patients statewide. She helped develop the 2018 and recently revised medical assessment and psychiatric admissions guidelines with the Virginia Department of Behavioral Health and Developmental Services, and she serves on its Protocol Review and Monitoring Committee, the PRMC. She received her medical degree from New York Medical College and undergraduate from Cornell. Jonathan Green joined Virginia's magistrate system in 2009 and has served as director of the Department of Magistrate Services at the Office of the Executive Secretary of the Supreme Court of Virginia since 2019. He served as the chief magistrate of the 10th District for 3 years and became a magistrate advisor focused on mental health issues until becoming department director. Prior to joining the system, he practiced law as a solo practitioner in Mecklenburg County and served a term as the elected Commonwealth's attorney there. He's a graduate of Campbell University, North Carolina, where he earned his BA in history and JD in '95. So a note to our guests today, if you have questions, please add them down to the Q&A section or the chat, either one. I'll monitor them both bottom of your Zoom window, and our panelists can answer them once they get through the presentation. We're also recording today's session, and we will provide it to everyone in about a week once we get it all packaged up. So next, I'm going to hand it over to Dr. Sequeira to give a presentation. She and Jonathan Green will talk through it, and then they'll have a few questions for one another. And then in the last 10, 15 minutes or so, we're going to keep this right at 1 hour. We'll take your questions and ask them. So thank you all for being here. I'll turn it over to our doctor.
Hi, everyone. Thank you very much for joining. So the reason we put this webinar on is because there's been so many questions surrounding ECOs and TDOs, the language that's in the code, and hopefully to kind of help understand a little bit better what the differences are. So I'm just going to jump right into it. So first of all, right, within the Virginia Code, it talks a little bit about what are magistrates, and basically magistrates are independent judicial officers, and they are beholden to the Virginia Code and the language within the code as to what they are and aren't allowed to do. And there's different regions, and different jurisdictions within Virginia. So one thing I always tell people that, when I'm giving this presentation is make sure you know who your magistrate is. Make sure you have the Office of the Magistrate phone number in your phone. Should you ever need to petition for a medical ECO, mental health ECO. So always having that number kind of on hand. And I'm also going to let Jonathan chime in whenever he wants to as well, okay?
Well, let me throw out one thing then, going back to that last slide, since we have the map up there.
Yeah.
When you talk about the know your local magistrates, I just want to point out each of those colored regions are one of 8 different magisterial regions. Those are led, if you will, by a magistrate regional supervisor. And then within those regions, there are multiple districts. Those are the smaller blue numbers that you see depicted there. And in each one of those districts, there is also a chief magistrate. So if you have questions or concerns or just want to talk through some local matters that seem to pop up, I'd highly recommend you reach out to your chief magistrate and or your regional supervisor, since they will be the boots on the ground and leading that particular area where your facility is located.
Thanks, Jonathan. So let's jump into it. So when it comes to mental health, so there's the mental health ECO. We hear it called all different things. For the sake of this talk, I'm using the word mental health versus behavioral health versus psychiatric. So mental health ECO, emergency custody order. So basically, it requires a petition to the jurisdiction's magistrate about who can issue the order. It places an involuntary patient. That means a patient who's unwilling to come in under law enforcement custody and to be brought in for CSB evaluation. Now, it can be brought into any location. So CRCs, for example, it doesn't always have to be an emergency department. However, this is what's most often happening in Virginia, just because we don't have that ability quite yet. But it is something that the state is looking into, is how do we avoid bringing patients all the time to emergency department if they don't necessarily need a whole medical evaluation by a physician. Patients under the law enforcement custody while that disposition is figured out, it may transition to a mental health, TDO. And so one thing I always tell people is that, ECO means evaluation in the ED. It's just a quick way of remembering that. So it doesn't mean that a patient is definitely going to be under a TDO. All it means is just getting evaluated by a CSB, somebody from the CSB. And so in order for a magistrate to issue the ECO for mental health crisis, right, first the patient has to have some kind of mental illness that can cause serious harm to themselves or to others. And they might be suffering harm due to their lack of capacity. And due to their lack of capacity, they might be unable to provide for themselves, right, their basic human needs. So we see sometimes patients coming in for that reason as well. They're obviously in need of hospitalization or treatment, and they're unwilling to volunteer or incapable of volunteering for hospitalization or treatment. So we'll talk a little bit about this as a question later on, kind of about capacity, and to ask Jonathan Green about that. So hold tight on that one. One thing I do want to just mention is that, we have a lot of patients who have schizophrenia. We have a lot of patients who are homeless with schizophrenia, but if they're not a harm to themselves, right? If they're not, their lack of capacity is not causing them to not take their medications or whatnot, take care of themselves, they're not necessarily a harm to themselves. And so a lot of these patients are, happily homeless and are not necessarily hospitalized for that reason. So just want to make sure everybody understands kind of the difference. And the other thing is that anyone can petition the magistrate for an ECO, right? So it could be a family member. We see this all the time, CSBs, a nurse, a doctor, EMS. So when we're in the emergency department working and a patient comes in voluntarily, and then all of a sudden we think that they might be concerned for suicidal thoughts or homicidal ideation. Our job, we can call the ECO. So I've done that several times. Nurses have done that. Most of the time, CSB workers or another licensed clinical worker is calling. But just know that we have the ability to do that and to petition. Again, does not mean that they will be admitted. It's just getting that evaluation. So how to petition for a mental health ECO. So we talked about the 3 criteria. And then you basically petition your jurisdiction's magistrate. There is a mental health ECO form. It's called a DC 4001 form. And so that's the petition form that you'd be using. The magistrate, after talking with them, after faxing, will issue the ECO. Law enforcement officers will arrive, bring the patient to the emergency department, and then the patient is under that mental health ECO for 8 hours. The law enforcement is under custody with them one-on-one during this entire time. So one of the questions that I've gotten that asked before is about how, when it comes to mental health ECOs, do you need to be in person to petition versus just the phone call? So Jonathan, if you don't mind just answering that question about, does an ED physician need to be need to be in person to petition?
Sure. Here is the challenge for the magistrate, and the statute doesn't specifically discuss physicians other than to say they may petition for the ECO. We are cognizant of the fact that it is difficult for an emergency department physician to leave that facility and appear before a magistrate. But the trade-off is we cannot administer oaths by telephone. We can only administer an oath to get sworn testimony either in person or over a video system. There are some ways we can work around. You can fax the petition to us, but the magistrate is going to want some level of comfort that they know they're talking to a doctor, that this isn't just a disembodied voice on the phone saying, I'm a doctor and this person needs to be ECO'd, because we have little way to verify that. We do work with CSBs quite a bit over the telephone. We have protocols in place for being able to identify them. And so if you're running into frequent concerns about, well, the magistrate is asking me to appear on video or come in, it might be worth having a discussion with the chief magistrate and or regional supervisor to say, can we develop some sort of protocol, list of ID numbers or something like that, so that the voice on the phone can say, I'm Dr. Smith, my ID number is 12765, I'm at the local ER and I'm seeking an ECO for this person. That will help the magistrate know, that voice on the phone is in fact a doctor and not someone up to some sort of mischief.
Right. And that's actually what I would recommend as well. And so we each have NPI numbers, right? So all of us providers. And so if we give our NPI number, for example, that's one way of them double checking that it's a doctor on the phone. But I agree, like talking to the chief magistrate really is key here, and giving that list of physicians that work in the emergency department, APPs that work in the emergency department, as well as their NPI numbers for that double check. Great. So no petition mental health ECO. So it allows a magistrate to issue a mental health ECO either based on sworn petition, just like we were talking about, or upon on the basis of sworn petition or upon the magistrate's own motion.
And to follow up with the earlier question, if you're submitting a DC 4001 by fax and you haven't had that notarized, we can't legally consider it a sworn petition because no one has been placed under oath either by the magistrate or by a notary when signing the petition. So in those cases, the magistrate, if they decide to issue, would be issuing on their own motion. And that's another reason why they want to verify the identity of the person they were talking to on the phone.
Got it. Okay. So that's actually good to know, so that petition, faxing it over, is not a sworn petition, but rather on the own motion of the magistrate. Thank you. So law enforcement then officers initiate the ECO. They can also initiate the ECO based on their own observation. So you guys hear about the term paperless ECO. So that is essentially the paperless ECO. And so that is also dictated in the code. Obviously, the petition is preferred. So what happens over the next 8 hours? So you guys are pretty familiar with this, right? So CSB is evaluating the patient. They do a pre-screening form. They try to formulate a least restrictive method, a plan. So we don't want every patient necessarily needs to be admitted, right? We can figure out some outpatient options. And it depends on the resources that are available in your area. As ED providers, right, physicians, PAs, and Ps, our job is to make sure patient is safe, staff is safe, whether we're doing physical restraints, sometimes chemical restraints, or just treatment for acute agitation. And the key here is that when it comes to acute agitation, right, standard dosing of your Geodon, Haldol, whatever you need to, basically, it's not to snow them, it's not to sedate. The idea is to get them to a place where they're safe for them, to themselves, safe to others, and can participate in the interview. They can, participate basically in the interview and not cause themselves to injure themselves, rhabdo, anything like that. Our job is also to start any maintenance medications if they're on home meds, starting those. In terms of medical assessment and screening, so this is something that's a hot topic and very near and dear to my heart. So, I was involved in the 2018 medical assessment guidelines, and we call it medical assessment and evaluation, not really screening, because it's truly that. You're trying to assess if they have any medical problems that makes the patient not be able to go to a psychiatric hospital. So what is on us as providers is we need to make sure we're reassuring the psychiatrist on the other end, right? And what that means is documenting pertinent history, physical testing to ensure safe inpatient admission. So that means that it's on us to do to talk about the pertinent negatives. They don't have dysuria, hematuria. because they need to hear that there's no UTI symptoms, and that's why you didn't order a UA, right? If your white count is 12 or 13,000, we need to document, it was 12 or 13,000, not because there's concerns for infection, but rather it was a stress response related to fighting against the cuffs, right? So that's on us to have to document all that stuff. With the changes in 2024 with CMS documentation, right, it took away our review of systems. And so that's been a little bit of a big change for psychiatrists to see, is not having a whole pertinent review, a negative review of systems. So that's why it's more imperative that in our HPI, we're talking about pertinent a negative review of systems. And then discussions with the psychiatrist. So this is also key, within the code, it allows us to, as ER physicians, to request a doc to doc. It's really provider to provider because we understand there's APCs on both ends. And so that guidelines that we refer to, which is on the DBHDS website, VHHA website, and VACEP website, they all talk a little bit about how to initiate a doc to doc, right? So if you're hearing from CSB, hey, this state hospital is asking for this and this test, and you're like, they don't need this test, that should start the process for doing a doc to doc. And usually, I would say majority of the time, like 80% of the time, conversations end in having, in figuring out the problem and moving forward without the test or with the test. Sometimes I've been convinced to get an EKG or to get that blood test, and when I understand the why on their end. And most of the time, the why is related to timeliness of being able to get that lab. So, we have the ability, the luxury of getting tests back very quickly. But unfortunately, in a lot of these psychiatric institutions, they don't have that ability. So in order to get a mental health TDO, right, they don't necessarily have to go from ECO to TDO. They might be just involuntary or not have the capacity to make that own decision and then be TDO to a psychiatric institution. Once the facility accepts that patient, that's it, then it's issued. It's actually that same form. Law enforcement or alternative transport brings patient to that facility. So the code does allow for non-law enforcement to bring patient to that facility. There's a lot more details to that, but that is a possibility. Bed of last resort. So this came out several years ago under CRE-DEEDS. So after 8 hours, when no private facility has accepted the patient, the state hospital must accept. And we know this, right? Delayed acceptance because of violent behavior, resources to take care of these patients, intellectual disability, autism, multiple comorbidities, malingering and alcoholic. So we've got a lot of different reasons why sometimes these patients sit in our ER for a really long time. And the patients don't, after 8 hours, there's still no place and state hospitals are full. They end up still sitting, waiting. And then sometimes we try for private hospitals again. Or we do put the TDO to the state hospital, but unfortunately, until a bed opens up, they sit in our ER. And so sometimes, we detain that involuntary patient in the emergency department for up to 72 hours, and that has happened. And a judge has to hear the case at the end of that 72 hours, which is something called a commitment hearing, to see if they need to extend it for 30 days. Now, there is an exception, right? Just so you know that if that 72-hour period ends on a weekend or a holiday, it might be a little bit later because the office is closed. But note that it is 72 hours in majority of cases. Okay, so now going over to the medical ECO. So medical ECO is for a patient in a medical crisis without capacity. And this is key, right? Because it's a person, does not have capacity. Patients in Virginia, we are very protective of patient rights, and that's very much appreciated. So a patient can make a decision as to their own body, as to what happens, so they can choose not to come to the emergency department if they have the capacity. But the key is, what if they don't? So these are very, very rare, medical ECOs. And the reason why they're rare is because, so a patient, first of all, is not in the emergency department. So we don't call medical ECOs in the emergency department. And Jonathan will talk a little bit about the why later on. But ODEMSA actually has guidelines for EMS. So sometimes you might hear about EMS calling the ER for a medical ECO, but ODEMSA does actually give guidelines to EMS about taking patients in, patients who don't have capacity and bringing them in with opportunities for like chemical or physical restraint if needed. Now, only a licensed physician can petition for a magistrate in the state of Virginia, can petition the magistrate for a medical ECO. And then there's 5 criteria there. So one, the patient is incapable of making an informed decision, right? So they lack capacity. 2, they're unlikely to become capable of making that informed decision. Oh, and this is just the ODEMSA criteria. Sorry to put that in there. 3, they have no legally authorized person available to give consent. So this is also key, right? So just because the patient doesn't have capacity, if the patient doesn't have capacity, is there a next of kin? Is there somebody legally authorized to make that decision on the patient's behalf? Because sometimes there is, right? You've got your patient who's got dementia, who is living with their daughter. Daughter can make decisions for them. And so basically, this is the decreasing order of priority of who can make decisions, an informed decision on the patient's behalf if they don't have capacity.
And let me just add to the importance of the word available, because the way we train magistrates is that there's no legally authorized person available at that scene at that moment when we're being asked to issue the medical ECO. If they're out in the world somewhere and are subsequently located, that's great. But all we're focused on is there's no one on scene at the moment with the requisite authority to make decisions for the person.
Great, thank you. And then number 4, they've refused transport to obtain the treatment that they need, and that the testing, observation, and treatment are necessary to prevent harm to themselves. So I'm going to put all of this up there to show you just how much work it is to get a medical ECO. So I know like most of us have not done these, and so most of us don't know that it actually exists. But part of it is because it is a little tedious. So if EMS calls us about getting a medical ECO, then we have to communicate with the adult, try to figure out if they can consent, and then if they can't consent, then you try to figure out if there's a next of kin available. If there's no next of kin available, then we call the magistrate, we petition the magistrate for that ECO, then EMS brings the patient to the ED for evaluation. Law enforcement does for medical ECOs only. So medical ECOs, law enforcement does go to help EMS if needed, right? Sometimes EMS might not need it. But my thought is, maybe they're calling the medical ECO because they need that police officer help. But every jurisdiction is, again, a little bit different, and every about how willing law enforcement is to come there versus coming to the emergency department to serve the paperwork. It is a little bit different in all places, and every case is a little bit different. In the ED, the patient is evaluated by us, the licensed physician. If the physician determines that they meet the TDO requirements, then we can petition for a TDO at that point. But if they don't meet requirements, they can released from the medical, they can be released from custody. They remain under custody until this evaluation is performed, and the custody cannot exceed 4 hours. And if it's not executed in 4 hours, the order shall be void. And I know I got a question once when I was talking about this with EMS about why only 4 hours as opposed to 8 hours with behavioral health, mental health ECOs. And usually within 4 hours, we have an idea. Usually labs and testing are back. We have an idea if this patient is staying or going. And so that's kind of why the 4 hours. We're not doing a whole bed search or anything like that. So 4 hours is, I think, a pretty reasonable time to figure that information out.
And let me add as well that not so many years ago, the time limit for the mental health ECO was also 4 hours. And then they expanded that to 8, but they did not bring the medical ECO along with it. That remained at 4.
Yeah. And this is just saying that law enforcement can go beyond their territorial limits in order to help with the medical ECO. Okay, so then the medical TDO. So This can come about in many ways. So they could come in under medical ECO, but that's not the most common. The most common that we see in the emergency department is that the patient becomes involuntary, and they're trying to leave. So it includes patients who may be intoxicated and need a medical workup as well. And the patient is already in the emergency department and meets those 5 criteria, and so need to stay for whatever reason. It doesn't have to be because they need admission. Again, it just means if you need to do a whole workup on the patient, they're already in the emergency department, you need to do a workup to figure out what's going on. Are they acting this erratic behavior? Is it because of something as simple as intoxication, or is it because of a head bleed? It is because they're hyponatremic. There's all different reasons, right, where we know patients can be altered. And what a medical TDO does is it detains the patient for 24 hours. And with that, like, it can be released at any time. So how to obtain a medical TDO? So a licensed physician petitions the judge and or magistrate. And again, this depends on the time of day. It depends on your jurisdiction. Calling the office, faxing the TDO form to petition. Hospital. So the difference between, mental health, ECO, TDOs, and medical is that hospital security is responsible for keeping this patient detained, right? So police officers, law enforcement are legally not in charge of doing this, but they, most of the time, again, they do help us out, right? And so very important to kind of have that relationship with your local PD. And so hospital security is responsible for keeping the patient there, and then with the help of standard dosing of acute agitation medications to make sure that patient is safe. They're detained for 24 hours, but they can release at any time. And then after the 24 hours, a court hearing decides if the involuntary commitment is needed. So that's basically the quick presentation I wanted to give you, just laying out the differences. And so now we will go to some questions. So I'm going to stop sharing my screen so that y'all can see us all. And go to some questions. So these are questions that both Jonathan and myself get a lot of the times. Me being on this PRMC committee, I get questions fielded from a lot of emergency physicians as well as CSB, and even sometimes hospitals. So we talked a little bit about with mental health, Jonathan, about being physically present. And so just to be clear again, we don't, because our physicians don't have to be, we're obviously working in emergency department, hard to be physically present. Key here is working with your chief magistrate, making sure that they know that who is a responsible party making this petition, providing NPI numbers, names, work with your medical director, and working with the chief magistrate about that, so you don't have to physically be present there. I would also, if that's not already done and you're in a tight hold, I would still have them, there's ways to give them your NPI number, and see if that would work. So this is a great question that I get all the time. Does the mental health ECO, either through the code or through the petition paperwork, allow patients that have capacity, that means they can make their own informed decisions, to get testing against their objection for the medical evaluation for mental health admission, like getting routine tests?
Well, it's one of many areas where I'll say the code is not specifically addressing that particular issue. I think it's possible, but it may depend on the facts of that particular case and the information that's presented, to the magistrate. If the patient has capacity, so I'm assuming based on the question, they're either there voluntarily or perhaps were under an ECO issued on the basis that they were unwilling, but not so much that they were incapable. Now we're trying to transition to the TDO, and we need to get the medical screening done to facilitate their entry into the temporary detention facility in the TDO. So I wish I could give you a black letter rule of law that would say in every case yes or in every case no. I will say I think it's possible, but it will depend on the information that's available to the magistrate.
Great. Okay. And I think this is something that, Virginia ACEP and in the future, like, can work on in terms of helping make that code a little bit clearer. We're trying to figure that out because it is a question that we get all the time. Do you lose your capacity to make decisions under an ECO? And that's not necessarily true, right? There have been court cases relating to this. And so I think it is a little bit dependent, and I think it's always a conversation with the magistrate about that, about whether that patient, about getting that labs and such. Because obviously we don't want to force labs and urine on a patient either that has ability to make their own decisions about their body.
And another point as well is, as we all know, patient conditions can change over time. So the situation or their condition at the moment the ECO was issued might have been different than what it is right now when they are posing some resistance or refusal to cooperate with the medical screening procedures. And again, that would be very relevant information to convey to the magistrate that might support a decision one way or the other.
Great, thank you. And then other question is, does that change at all if the patient's under mental health TDO? So let's just say that patient is now, they're under a TDO now, and they're still in the emergency department. We might have to get more testing done for whatever reason. Does that change anything or not really?
Well, the challenge, once they're under a mental health TDO, the magistrate's role is pretty much come to an end unless there is a subsequent request for a medical process like a medical TDO. Because once a mental health TDO is issued, the next steps are going to happen or be performed by a judge or special justice. The magistrate is not involved in any further hearings and doesn't have the ability to issue additional orders to say require cooperation with that medical screening or testing that you're trying to administer. And the one exception to that would be if someone was able to come to the magistrate and say, we need a medical TDO, and they can convince the magistrate that the criteria for medical TDO are met, we could then issue that medical process. But we're done with the mental health side once the mental health TDO issues.
Okay. So during a mental health ECO, then, if a patient's not cooperating with the medical screening, the magistrate can issue some additional orders, but not so much when they're under a TDO. Is that correct?
Well, let me be clear about that as well.
Okay.
Magistrates are creatures of statute, so we can only do those specific things that the code allows us to do. We can issue a mental health ECO, we can issue a mental health TDO, and we can issue the medical processes if those criteria are met. But unlike judges that have a certain degree of inherent authority to issue additional orders to make sure the will of the court is carried out, all we can do is what the code allows. So if we issue a mental health ECO and the patient needs to be screened for admission and they refuse, unless someone can show the magistrate that it's appropriate to issue a medical TDO for that reason, we don't have another order we can issue to say, Mr. or Ms. Respondent, you must cooperate with the doctor to get this blood drawn or whatever the other sample is. We just lack that authority.
Okay, got it. And again, I think this is where legislation or work groups are getting some kind of discussion going in the future will help to just kind of make it clearer for the physicians who are on the front line trying to figure out what to do.
Now, and I understand it's a very difficult position, but one other thing I would point out, if you look at the language of the order that we issue, it is directed for the mental health ECO, it is directed to law enforcement to take that person into custody and to transport them somewhere. It doesn't order the respondent to do anything. It doesn't order the hospital to do anything. It's saying this person may be properly taken into custody and transported to this location for the purpose of undergoing an evaluation. But if they refuse or the CSB is unable to get them to participate, the magistrate can't go back in and issue another order saying you need to behave yourself and cooperate.
Okay, thank you. That's actually very clear. Thank you. Okay, so if a mental health TDO has a 72-hour commitment hearing in the emergency department and then needs another 30 days commitment, does the police remain with the patient or not?
And that's going to be another one of those issues where I tell you, I don't have a clear answer. The magistrate doesn't order it because we're out of the picture once we issue the mental health TDO. If a judge or special justice orders an involuntary commitment for up to 30 days, I think the statute, the way it's wording, assumes that the person will immediately be transported to a facility somewhere and that 30 days will start. But as we all know, that sometimes doesn't happen in the current setting. But whether or not law enforcement is obligated to stay, that is going to be a decision that that law enforcement agency would need to make in consultation with their legal advisor. So it wouldn't be appropriate for me to say, yes, they should, or no, they shouldn't. The code really isn't clear.
Okay. So imagine a mental health patient is in transit to a psychiatric institution and has a medical event, and this has happened, and they need to stop now at another ED. Do they remain under the mental health TDO to the hospital with law enforcement staying with the patient until the patient is medically clear, or does something change? Obviously, if they need a medical admission at that point, they can get a medical TDO, but do they just stay under that mental health TDO while in the emergency department to get cleared?
Well, and again, looking at the language of the code, which again doesn't give us a bright line answer to this, but the closest thing I think that's in there is in 37.2.810 subsection B, which is talking about transportation issues with mental health TDOs. And all that really says is that in cases where someone is being transported, nothing herein shall preclude a law enforcement officer or alternative transportation provider from obtaining emergency medical treatment or further medical evaluation at any time for a person in his custody as provided in this section. And then it goes on to say such medical evaluation or treatment shall be conducted immediately in accordance with state and federal law. So that's the only guidance that the code really gives us on that issue. Now, I think if a medical TDO then flows out of that unanticipated medical crisis, I'm familiar that sometimes law enforcement has said, well, now there's a medical TDO, so they're in the custody of the hospital. But I really can't point you to a section of the code that definitively answers that question. What happens to the mental health TDO? But since it's issued and in effect, it would appear to be in effect, but how law enforcement interprets their obligation is going to be up to law enforcement in consultation with their legal advisor.
Okay. Okay, moving on to medical, ECOs and TDOs. So I'd mentioned this before, but why can't a magistrate issue a medical ECO for a patient who is already in the emergency department?
Well, I think there are several reasons based on the language of the code. And for the medical ECO, we're moving a little further down in 37.2 to 37.2.1103. And if you look at various bits of language interspersed throughout that code section, in subsection A, it says the magistrate may issue for good cause shown an emergency custody order for the adult person to be taken into custody and transported to a hospital emergency room for testing, observation, or treatment. So sub A clearly anticipates that the respondent is out in the world somewhere and needs to be brought to the ED, not already in the ED. Going on to the criteria that are listed in subsection B, in order to issue the medical ECO, the magistrate has to find, among other things, that this respondent has refused transportation to obtain such necessary treatment and has indicated an intention to resist such transportation to get treatment. Well, if they're already in the ED, it's going to be hard for the magistrate to say, oh, they're refusing transportation for treatment and they're resisting efforts to transport them when they're already present. So that would be two of the criteria that the magistrate could not find were satisfied. And with these criteria for these various processes, it's not, a best of 7 thing. We have to find all of the criteria are met, not just 3 out of 4 or 2 out of 3. all of them have to be satisfied. And then lastly, I think there's one other section in there where it talks about, or it reinforces the concept that the respondent is not already in the ED, because it requires the physician communicate with EMS personnel on the scene. That's one of the requirements that the physician has to do before requesting the ECO. So if they're already in the ED, I think it would be hard for the physician to meet that statutory requirement.
Great, thank you. So one question I get a good amount is that, there's different jurisdictions in how you petition for a medical TDO, whether it's judge versus magistrate, certain times of the day. So one question I get is there a way to petition the magistrate directly for a medical TDO instead of the judge during business hours? If I have no idea what's going on with a patient could be intoxicated. Is that possible, or do I always have to go through the judge?
The challenge is, as many of you know, subsection B in the medical TDO statute, which is 37-1104, is a very recent addition, and that creates what I will just conversationally refer to as the intoxication TDO. Prior to that, the medical TDO was what's in subsection A, and a magistrate's authority to issue that, we have what we call contingent authority. A magistrate may only issue if the judge is unavailable. So that's why before this intoxication TDO was written into law, we would always defer to the judge. Now, obviously, if it was midnight on a Saturday, we know no judge is available, we'll jump right in. But if it's 2 p.m. on Tuesday, the magistrate is going to want some assurance that the judge is not available before going forward. I get the question. A patient has dropped in and you have no clue at this point what's going on. You need to evaluate them. You need to get some labs. There's some other things to figure it out. But I don't think a magistrate would be comfortable saying, because it's theoretically possible that intoxication might be what's going on here, we'll just treat this under subsection B and no, you don't have to see a judge. I think from our perspective, to make sure our authority is in place, we either need to have some evidence that intoxication is involved so that the case clearly qualifies under sub B, or if it's just up in the air, it would seem to be a generic medical TDO under subsection A, and that would require going through the judge first, assuming it's during regular court business hours. The other thing I'll throw out as well, again, we don't want to be too arbitrary with this, but the medical TDO is one of the few orders that a magistrate can issue that has a right of appeal baked into the statute. If you read a little further, anyone who is subject to a medical TDO has 10 days to file an appeal with the circuit court for de novo review. And that means the circuit court starts from scratch and reviews the decision that was made by either the lower court judge, special justice, or magistrate in issuing the medical TDO. So one of the things a prudent magistrate's going to do is make sure they have enough information to support issuance of such an order, and also make sure they have the clear authority to issue such an order. And so the issue about going to the judge first deals with the magistrate's authority to issue the order.
Okay, got it. And so in terms of proving they're intoxicated, we have a good number of patients who are intoxicated with alcohol is one of our most common issues, right? They're found down. We need to get a CT head to make sure they don't have a bleed. We're concerned something else might be going on. And they're clearly trying to leave. How do we, in terms of proving if we can't get labs on them, is it just finding alcohol around them, knowing that they are, they're a super utilizer of our emergency department and here with alcohol issues all the time, you can smell the alcohol on them. What do you feel like the magistrate would need in order to show that, they're intoxicated?
Well, let me say at the outset, this is going to be an imperfect analogy, but I hope you'll take it in the spirit in which it's offered. We sometimes run into questions about intoxication in the context of a criminal case, DUI. Now, I am not saying that a person that is subject to a mental health or medical TDO is in any way, shape, or form a criminal. I want to be clear about that. But in the criminal context of intoxication in DUI cases, sometimes it's really easy because we have the intoxilyzer result or the blood draw result that shows a blood alcohol content of 0.08 or better, and that's easy. But there are other cases where that is not available, and yet the magistrate can still find probable cause that a person is intoxicated. Issues with their speech, motor coordination, mannerisms, smell, odor of alcohol around them, and so forth. And that information is usually given to us by an officer. So bringing that into the context of this civil, non-criminal setting of intoxication, obviously, if you have labs, that makes it easier. But if you can relate to the magistrate indicators of intoxication, be it alcohol or some other substance, confusion, physical symptoms, nystagmus in the eyes, lack of coordination, all of those things. A magistrate could use those factors to determine that a person may be intoxicated, because again, when we issue this medical TDO, we're doing so at the legal standard of probable cause, which is much lower than the reasonable doubt standard that a trial court usually has to implement.
Okay. And that actually transitions really well to our next question about, when we're filling out the medical TDO form, being how specific we need to be, and especially when it comes to what treatment the patient needs. Like, how specific do we need to be on that? What is not allowed? What does the judge or magistrate cannot allow in terms of treatment? Is there anything related to that?
Well, the statute doesn't go very far into the details on what may or may not be allowed. There's only the medical TDO statute, 37-1104, and while we did add the intoxication paragraph to it, it really doesn't talk about limits about what may or may not be authorized. So that being said, from the magistrate perspective, what we would be looking for in the testimony presented in the petition form is some facts that justify whatever treatment is being requested. Now, we don't need to sit on the doctor's shoulder for the duration of the 24 hours, and we don't need the level of detail. We wish to insert an IV into the patient's left arm and all of that. But tell us what condition you're trying to treat and the general course of treatment, if that helps. I mean, if you want to write down every little thing, what we train magistrates to do is largely adopt what the doctor is putting in the petition, unless they're just requesting a blank check, treat any and all medical problems that may be going on with this patient. We're not going to be that broad in our authorization. But if you tell us the patient is in kidney, and I'm going to probably slaughter some medical terms or practices, so I ask your indulgence for that because I am certainly not a doctor. But if you have a patient who is experiencing acute kidney failure, you may want to do dialysis. You may want to provide some other sort of medication, either intravenously or orally or by some other method. You may even be requesting some sort of approval for a surgical procedure to address a particular issue. If you write that in there and you give us probable cause facts to believe that that's appropriate, then we should incorporate that into our order. But
Okay.
we don't need every single step in the process.
And what about psychotropic drugs to help us get to that point, right? So to get an IV on that patient, we might need to give them Haldol or Geodon. Do we need to write that in, or is that assumed? Because, and the reason I asked that is because we did have a case where, was told, oh, we can't do psychotropic drugs, even if it was standard dosing, in order to get the IV. I just wanted to be clear about making sure that that's allowed in order to keep that patient safe, keep us safe, in order to obtain these tests.
Well, I would say that a good rule of thumb is if you are going to ask the judicial officer, whether you're in front of a judge with this TDO or in front of a magistrate, If you're going to ask them to specifically authorize a particular course of treatment, like in this case, the administration of psychotropic drugs, then give us some facts that show that it's necessary in this case. We won't just do a blanket authorization. Just in case you need to do it, you can administer these drugs. But if you tell us this patient is anxious, combative, hallucinatory, whatever the reason that you think you might need to do that may be, give that information to the judicial officer so that they can see, okay, this may be a reasonable course of action because of this person's condition.
Okay. So while obtaining a medical TDO, we have a lot of issues with getting the patients to stay while we're trying to obtain it, right? We're on the phone trying to go through the judges to see if a judge is available and such. And meanwhile, this patient is running out of our ER and obviously they don't have capacity, so they could get hit by a car, bad things can happen. Who is responsible for helping? While we're obtaining, can law enforcement or security, I mean, I recognize with medical TDOs, it has to be hospital security, but help detain that patient to avoid them running out of the emergency department, even if that TDO is not officially in place, but we're trying to obtain it.
And I would say that might be a reason where we need one more member on this panel, someone that advises law enforcement. Obviously, we haven't issued a medical TDO at this point. And even if we do issue a medical TDO, it should be pointed out that the medical TDO doesn't direct a law enforcement agency to do anything. It doesn't have any language in it for transportation because the TDO statute and the order that is based on it seems to assume the patient is already at the facility where they're going to get the treatment they need. It doesn't direct law enforcement to take them into custody. So for law enforcement to get involved, a law enforcement agency would need to feel they had some legal authority to do so. And I don't want to sit up here and posit, oh, they can do it under this different code section or that one. That would be a judgment call that law enforcement agency would have to make.
Okay. And same thing, I guess we would talk with our local hospital security team about the same idea of if they're running out of the ER, working with our security on helping.
Yes, if they're not already in custody pursuant to some sort of judicial order, there would be nothing that a magistrate could issue that would say, we're going to authorize you to hold this person until the rest of the legal process runs its course. We don't have that authority.
Yeah. Okay. And then my last question, I know there's little time for other questions, but hopefully we might be able to go over. Can we seek a medical TDO to get a patient transported to another hospital? So let's just say I need a specific, the patient needs a specific treatment that's only available at an outside hospital. Can I get a medical TDO to transport that patient to another hospital?
Well, you could seek a medical TDO, and if the criteria for it are met, the magistrate could issue it. But this is going to be the challenge that you then run into. As I just mentioned, the medical TDO doesn't order anyone to take the person into custody. It puts them in the custody of the facility they're going to get care in. And there is no language in that TDO, unlike the mental health TDO that we talked about earlier. The medical TDO has no direction for anyone to transport that patient to a different hospital. Now, if you get the medical TDO, if your hospital and the hospital that would ultimately provide the treatment feel like you have the authority and can work through it and get the patient moved, great. But the magistrate would not be able to give you a written authorization saying, put this patient in an ambulance or a helicopter and shuttle them to the other facility to get this treatment, because the code does not give us that authority.
Okay, so those are all the questions that Jonathan and myself have gotten over the year or so. So we're going to open it up to questions from the group. I know we've got a lot. And Jeff, is it okay if we go over?
Yeah, absolutely. We'll stay on a few minutes longer. I will say, if anyone does have to leave, we are making a recording of this and we'll have it out sometime next week. But if you can join us for the next few minutes, that'd be great. Dr. Sequeira, I've put a few of those questions on our sheet there, so you'll see 4 that have come in if you want to go over those.
Sounds good. Give me one second. Okay, so let me just read this quickly. Okay, so what if a patient is brought in under a mental health ECO determine they need a mental health TDO, but the ECO runs out before the patient's medically cleared. Patient is willing to get medical treatment. How would that work if the patient is consenting to medical care? Do we just issue the mental health TDO once the patient completes the medical care? How do we avoid them from leaving if the ECO elapses and unable to get a medical TDO? So I would say this, if the patient is willing to get medical treatment, and you're still medically clearing them, I've never had an issue where the police just leave. Like most of the time, if they're voluntary, well, they're not voluntary, but they're willing to get medical treatment, we just continue on with that, and continue with, and then your CSB is continuing to work on getting a place for that patient. I don't think you necessarily need to go switching to a medical TDO to keep that patient there and then back. The other option is, though, if the patient comes in and you know right away this patient might end up needing to be admitted, you can then go to a medical TDO. But for the most part, it's trying to clear them in the emergency department. And I think the biggest thing that we see is poisonings, right? Ingestions. They have to be clear for 6 hours, 8 hours. You can switch to a medical TDO, but I have also seen the search just start after that. Jonathan, do you have anything to say about ingestions and clearing?
The mental health ECO statute 372808 says the person remains in emergency custody under that order until either a mental health TDO issues, a medical TDO issues, the person is released, meaning they were evaluated and the CSB says, oh, there's no need for further involuntary process, or once 8 hours elapses. Now, if they're released from formal custody under the ECO, but they say, hey, I'm willing to stick around and participate in medical treatment, then I would defer to the hospital on whether they can continue to deal with them or not. The magistrate doesn't come in and start making phone calls and say, hey, the 8 hours is up. Have you let this person go yet? That's not our responsibility. But I do think there is a question about what their status is. And so the hospital would need to take whatever steps it feels appropriate to be comfortable in continuing to treat the person.
Does a medical admission while on a mental health ECO halt the process for the mental health TDO?
Well, again, because the mental health ECO is not a required prerequisite for the mental health TDO, if there's an intervening gap, let's say of several days, where a medical issue is sorted out and the person is voluntarily consenting to treatment, the hospital is perfectly comfortable with treating them for that, that doesn't mean that once that medical issue is resolved, someone couldn't start back up with a request for a mental health TDO. So that it's not an automatic disqualifier, but the criteria would need to be for the mental health TDO would have to be met at the time that the medical treatment was resolved. We couldn't say, we issued mental health ECO for you 3 days ago, so we're going to look at your status 3 days ago instead of your status as you are today.
If the 8 hours elapses, an ECO 8 hour elapses, and a TDO was not secured, if the patient wants to leave, can they?
Well, let me answer this very delicately. The magistrate would have no role in that. The language that I just cited in 372808, which is the ECO statute, it's subsection K, and it says the person shall remain in custody until one of those 4 things happens. A mental health TDO issues, a medical TDO issues, the person is released, or the emergency custody order expires, and it expires at a period of time not to exceed 8 hours from the point where it was served. So if none of those other things have happened and 8 hours has come and gone, I think there's a legitimate question about what authority anyone would have to hold this person against their will. But again, the magistrate doesn't follow behind it and start calling people and demanding that the person be released.
Okay. So we've been running into an issue where our patients are unable to obtain a 72-hour hearing due to issues obtaining appropriate staffing and independent evaluator. Is there any level of advocacy occurring to assist with issues like this?
Well, again, from the judicial branch perspective, we tend not to take policy decisions or advocate for or against particular policies. I think, and I would certainly defer to the folks in the executive branch, but I believe DBHDS, among others, has been looking at ways to improve, the flow and the process and bring more available resources to bear in the field of involuntary commitment. But there's a lot that has to happen before a person can be put before a judge or special justice for the involuntary commitment hearing. And one of those things is the evaluation that has to take place. And since that's outside of the judicial branch, we don't have something that we're trying to push in that area.
This is something related more to criminal cases. So, but when a patient is brought to the ED in custody for crime, can the patient refuse treatment? I'm assuming if they have capacity. When statement from patient in police custody that is a discussion with staff to let treat due to potential infection with wound, but states, I don't care if I die. Does that now need a mental health TDO? Police stated that under custody, hospital staff could perform care even if patient with capacity stated no. Okay. Okay, I understand. So they're basically coming to the emergency department. They're maybe on their way to jail. They have a medical issue, like a big wound. Let's just say they got cut. They have a large, maybe a wound infection. Maybe it's just a laceration that needs to be sutured up. But they're like, I don't care if it gets sutured. I don't care if I don't take antibiotics. I don't care if I die. At this point, I guess the question is, do they need a mental health TDO for saying, I don't care if I die from this potential infection?
Well, I think there are a couple of possible options, but the ultimate outcome will depend on the specific facts of that case. You could consider a mental health TDO, but if they're already in criminal custody and they're being transported to jail, I think that was the example in the hypothetical. If they are in legal custody and considered an inmate in the custody of the jail, then only the jail can petition for an inmate TDO. That's under a different code section that we haven't been talking about yet, 19.2-169.6, I believe. So there's some different rules for that. The other thing is, the problem really sounds like it's a medical issue that you're trying to treat, not a mental health issue. Yes, I understand. I don't care if I die or not, suicidal ideation, but the real problem is that large wound on their arm. Mm-hmm. So they might meet the criteria for a medical TDO in such case. And again, depending on their custody status, if they are already considered an inmate of the jail, if they've been committed to jail, then there are different statutes in Title 53.1 where health care for an inmate can be authorized pursuant to those statutes.
Okay. Thanks for addressing the physical restraint aspect of helping a patient who is actively trying to leave. If a patient is actively attempting to walk out of the emergency department while we're trying to obtain a TDO, then can we legally give sedating anxiolytic medications to facilitate their facilitate their safety?
Now, I would have to say the answer to that question is way outside of my area of experience and expertise, because that would not be done on the basis of a magistrate order at this point, because the magistrate has not issued any sort of order. So I think that would be a question for either your group, Dr. Sequeira, or the hospital to have with its legal counsel to decide what they could or could not properly do in that case.
Right. Okay, sounds good. And it sounds like, yeah, that's conversations with your risk team and your security team. about giving medications for these patients who don't have capacity and are leaving and are trying to walk out, and obviously for their own safety and even safety of others. Then the next question I have here is, does there have to be a break in custody before a subsequent TDO can be issued when someone poses a clear danger to others and the initial TDO expires prior to acceptance to a willing facility?
We get this question quite a bit, actually. There is an Attorney General's opinion that has been around since, I believe, 1996. So the longer, if you're familiar with those, the longer an Attorney General's opinion stays out there, the more presidential weight that it gets. And this AG opinion specifically says a magistrate can, and I'm paraphrasing the language here, but a magistrate cannot string multiple TDOs together to keep a person in continuous custody for longer than the legislature authorized. So in this particular question, if they're under a mental health TDO, and as we saw from the earlier slides, that normally runs for 72 hours, but has that one little exception where it could be extended a little longer if the 72 hours ends at a time that court is not in session. If that TDO expires and for whatever reason, no one was able to get everything together to move on to the next phase of the involuntary commitment hearing, it would be inappropriate for a magistrate to come in and say, I'm going to issue a second TDO so you can hang on to this person and buy more time to get everything that you need to get done for the involuntary commitment hearing. We understand that doesn't fix the underlying issue, that the person, if they're suicidal or danger to themselves or others, we certainly understand that. But the Attorney General interpreted that statute and said the legislature set the time limit that they set. And so it's not appropriate to string multiple types of the same process together to get around that time limit. And so that's why the magistrate will say, I can't issue a second TDO to let you keep the person in continuous custody. So if they are released and then someone comes in and gives us information that all the criteria are met, we could issue another TDO at that point because it's no longer successive since the person was released. But that's the reason we do that. It's not a decision we reached on our own. We are trying to comply with legal guidance that the Attorney General's office gave when interpreting the TDO statute in the code.
Okay. We've got actually a couple good questions coming up. So I know we're short on time, and I do want to hit some of these. If someone comes in with altered mental status, agitation, possibly psychiatric, like they have a history of schizophrenia, but we do need to rule out a medical process. They're not cooperative. What would you recommend? Would the initial course be getting a medical TDO or going ahead rather than getting a mental health ECO?
The challenge really is I can't give such a recommendation because then I'm stepping outside of my role as a neutral and detached judicial officer. I think obviously you would want to look carefully at that. You know what the options would be based on our discussion to consider either a mental health TDO or possibly some sort of medical TDO or medical process since they're already in your facility. But I really can't say based on those facts, you should do one or the other. You just have to evaluate and see which one you think might be more appropriate for that patient's condition.
Okay. Regarding the 4-hour period when their patient is under a medical ECO, is the law enforcement required to stay in the ED during that 4-hour medical ECO period?
Well, again, with the medical process, with the medical ECO, that does direct that the person be taken into custody and transported. But then the question of how long, if at all, does law enforcement stick around? Ultimately, that is what the law enforcement agency has to determine, what its legal obligations are. So I'm not able to say they should do this in this particular way. Again, there are some gray areas in the statute, and so we defer to law enforcement and their legal advisors as to what they need to do to honor their obligations.
So I recently took care of a patient from a skilled nursing facility where a medical ECO was obtained, but I actually disagreed with the skilled nursing facility physician saying that the patient didn't have capacity. I felt like the patient did have capacity, which puts me in a murky gray area. Should I recontact the magistrate, or do I obtain another physician's opinion in that case?
So now that, as I understood that question, that was dealing with a medical ECO.
Correct.
All right. Once the medical ECO is issued, we're done with the medical ECO. Now, there is some language in the medical TDO statute where if additional information comes to light such as religious preferences of the respondent or family member objections to the proposed course of treatment, that statute does require that the party becoming aware of that, usually the physician, make the judicial officer that issued it aware of it. And the statute gives the judicial officer the ability to modify or even terminate that order. That's not the case with the medical ECO. So a magistrate would not have the ability, once that emergency custody order has been served on the person, we can't go in and modify it or change it or do anything to it.
Okay. And last question, patient is brought to the emergency department on a mental health ECO, and they're refusing even initial vitals. So forget even labs, they're just refusing vitals. They demonstrate no psychotic or dangerous behavior on arrival, and they say, no, you may not touch me. Can we check a pulse and blood pressure without their consent, or not?
And I'm sure I'm beginning to sound like a broken record, but I'll have to do it one more time. I really can't answer that question on behalf of the medical staff, because that would be something you would want to talk to, I believe, as you put your risk management team or others on what your legal authority is. If we've issued the order directing they be transported to that location, we're done with that part of it, and we can't get back under the hood and issue some sort of follow-up process saying, patient, you must cooperate with doctors and nurses and so forth while you're here. We just lack that authority.
Okay, great. So just due to the interest of time, we're going to stop there with the questions. However, Jeff, if you don't mind, just keeping those questions, any additional questions that we might have gotten, because, right, so Jonathan works with advocacy on a magistrate perspective. VACEP works as well, with advocacy. We've got colleagues who work with VHHA, with the Attorney General's office. And so all of this is helpful in hearing where are the gaps in our code and where do we need to kind of fix some loopholes and kind of help with making things a little bit clearer for those on the ground. So I do thank everybody for your questions. They were all very great questions. Jeff, I don't know if you have any ending comments.
Nope, that's it. If you all have any questions or you want to get in touch, VACEP, VACEP.org, you can go to the contact page and those questions will go straight to one of our physicians and we'll get back to you. So thank you all for joining us today. We hope you all walk away with greater knowledge than you had an hour and 14 minutes ago. We will make a recording of this. We'll have it available sometime next week to anyone who's registered. Share it around. It'll be on our website. You'll get in your email. Thank you all and have a great weekend.